first need to introduce myself. I'm Clinton Boyd Jr. I'm a researcher at Chapin Hall at the University of Chicago. For anybody curious to know more about the work that I do, feel free to, as Charles Barkley and Shaquille O'Neal would say, Google me. Um, and it's a lot of stuff that will come up. But for our first presenter today, we have Christina uh, Padilla, who is a research scientist in the early childhood department at Child Trends, and she will be presenting on behalf of the Child Trends team on their project entitled the McVie Advancing Health Equity in Response to the COVID-19 Public Health Emergency Project. And so Christina, I'm gonna turn the floor over to you and allow you to move forward with your presentation. And once you're done, I'll then introduce our next set of speakers.
Great, thank you, Clinton. Let me try to share. I am used to Microsoft Teams, so we'll see how this goes. Can everyone see those slides? Okay, great. Okay, so as Clinton mentioned, today I'm going to be talking to you about a project that I've been working on with a team at Child Trends, who I'll introduce in just a sec. But I'm going to be talking to you about mapping social determinants of health and McVie-funded programs to begin understanding how home visiting can advance health equity. So before I get started, just need to give you our little spiel. This project is supported by HRSA within HHS, but the information or content and conclusions that I'm going to talk about should not be construed as the official position of HRSA, HHS, or the US government. So before I get started, I just want to really reiterate this effort is certainly a team effort. So like I said, my name is Christina Padilla, and I'm going to be presenting on this work today. I'm a research scientist in the early childhood department at Child Trends, and I'm going to be talking to you about a piece of this project that I've been working on with my colleagues Winnie Lee and Jess Warren, and you'll hear a little bit from Jess later. Actually, she's going to do a demo of something we've been working on. I also want to acknowledge the rest of my team members, many of whom are here today, so they can answer some questions as they pop up if you have some about other aspects of the project. But the PI is Sarah Crown, the co-PI is Dina Around Him, the PD is Daniel Hegseth, and we have many more fabulous team members at Child Trends.
Christina, I'm going to pop in just for a sec because you're actually showing all your notes, so I'm not sure if you wanted to do that. Yeah, okay.
How do I not do that? You know?
So you can go to display settings right at the top. So if you, sorry, you can go back to the
presenter view
as you did. And then on this black screen, do you see where it says display settings at the top in the middle?
Yes.
If you click that, and then you can say swap presenter view. And then we'll go ahead and get the presenter view version. Yeah, that looks great. Thank you.
Okay. Thank you for letting me know, Sarah. And now it's just going to look strange because I'm going to be looking at a different screen, but that's okay. So you all can see these slides still, though? Okay.
It looks great.
Okay, great. So as I think Clinton mentioned, the work we're going to be presenting today is part of the larger, HRSA-funded project called the McVie Advancing Health Equity in Response to the COVID-19 Public Health Emergency Project. And the overarching goal of the project is really to understand the role of home visiting in advancing health equity during COVID-19 and hopefully other public health emergencies. Not hoping that they happen, just hope we can understand home visiting's role. The overall project takes a mixed methods approach that includes secondary data analysis that's going to inform our selection of 5 different communities with McVie funding for more in-depth case studies that are going to involve interviews and focus groups with community members to understand the ways in which home visiting supported communities during the pandemic. Today, though, I'm just going to be talking to you about the secondary data analysis piece. So a really cool and important part of this project is that we've been gathering input from a set of community advisors throughout the life course of the work. So our community advisor group is made up of MCV awardees, families receiving home visiting, community leaders, model developers, COVID-19 researchers, equity experts, and local implementing agency staff. And the reasoning behind continuously gathering community input is that we all, like to think we bring important methodological and content expertise to the work, but we also are recognizing the need to meaningfully engage advisors throughout the life course of the project to more equitably incorporate diverse community perspectives and expertise. And I'll talk a little bit more about how that's come up in our work. So our secondary data analysis is really intended to answer these two questions. Which communities were at a high risk for responding to a public health crisis and have had disproportionate COVID-19 impacts? And how do these communities overlap with communities that have MCV-funded home visiting programs? So there are three components to our secondary data analysis that I'm going to breeze through and talk to you about today. The first is that we are analyzing COVID-19 statistics to examine patterns across counties. We are creating a county level index to tell us about each county's pre-pandemic social determinants of health, or the resources that communities had at their disposal going into the pandemic. And then we're creating a national map to visualize COVID-19 statistics, those scores from that index, counties' demographics, as well as which counties have MCV-funded programs. So before I get started, and we'll come back to this diagram later, I'm sure you're all very familiar with it at this point, but just so we have it in mind, when we're thinking about the precision paradigm, the work that I'm going to be presenting today fits into this context box over here. So all of our activities, from analyzing COVID data to creating this index and the map, are aimed at helping us to understand a community's context as it relates to COVID, with the goal of understanding how that community's context during, for, and after COVID can affect home visiting implementation, or will affect it. Okay, so the first piece of our analysis is that we've been looking at COVID-19 statistics to help us understand how COVID affected different counties over the course of the pandemic. So we've been examining COVID cases, hospitalizations, deaths, and vaccinations in each county. And our approach is to look at these statistics as well as the correlation between them. So for instance, the correlation between cases and deaths. In some counties, this correlates pretty highly, and in some others, not as much. So we want to know, what's going on in those counties. And we're going to be looking at these over time to understand how different counties experienced COVID. And I should say, ideally, from an equity perspective, we'd also be looking at these COVID statistics by race and ethnicity, because we all know that while race itself is not a risk factor for COVID-19, racism is certainly deeply embedded in health systems in the US, as well as systems like housing, education, and wealth that can affect COVID-19 outcomes. We also all know, unfortunately, by now that Black, Indigenous, and Hispanic communities have experienced disproportionately high death rates from COVID, more limited access to services and resources related to COVID-19, and a lack of adequate data. These are the communities also that have been experiencing historical and ongoing traumas that limit trust in US institutions and the healthcare system. So all things that are important to kind of keep in mind when we're thinking about interventions. A major challenge for us, unfortunately, is that not all places report COVID-19 data by race and ethnicity. And even in places that they do report it, there's a lot of missing data. So whether these data are missing or not, or are even collected in itself, tells us a lot about inequity and historic disinvestment in a community in and of itself. But we've been mindful of this throughout the project and are trying to kind of keep that in mind. But kind of moral of the story is that instead of looking at COVID data by race and ethnicity, because it's not super available across all counties in the US, we're instead examining COVID data alongside county level race and ethnicity data taken from the American Community Survey as part of the analysis and as part of that case study selection that I mentioned. Okay, so one way to think about, just to give you an example of one of the ways that we're thinking about COVID data in our analysis is considering the number and the duration of spikes in COVID-19 statistics over time, and then comparing those things across counties. So for example, we can see here, this is example county number 1. This county experienced 2 spikes in COVID cases from 2020 to 2022. Each of these spikes is highlighted in yellow. You can see that in this second spike, cases went up to about 400 per 100,000 people. This is, in comparison to example county number 2, where there were more spikes. So we see 4 of them here. And this first spike in 2020 lasted for a lot longer than this initial spike in the example county number 1. But you'll notice that this y-axis is on a different scale. And so we can see even the highest spike in this county was at a significantly lower level than the first example county. So COVID-19 is one sort of piece of information that we're looking at. The second piece of our analysis is creating an index, which we're calling the County Response Index to support home visiting, or the County RISE HV. And the goal of this index is really to help us understand counties' strengths and challenges to achieving health equity going into the pandemic. And the index is made up of indicators of counties' social determinants of health, which I'm sure many of you are familiar with, but just in case, those are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And as I mentioned, we are taking all data on social determinants of health from right before the pandemic, so ideally 2019 or soon before, because we really wanted to understand counties' resources going into the pandemic. So here's a list of indicators that are currently represented in our index, which are grouped into the 5 social determinants of health domains. So I won't read all of them. You can take a look, but you can see they're kind of broken down into economic stability indicators, healthcare access and quality, education access and quality, neighborhood and built environment, and social and community context indicators. These indicators are drawn from about 15 different data sources, and we're happy to talk later if there are questions about how they've been aggregated, but for now, I'll just kind of leave you with this high-level information. And I will note too that indicators in orange are those that we added to the index after hearing from our group of community advisors. So as I mentioned earlier, this group has been engaged from the beginning of the project, and we showed them a list of indicators pretty early on, and there were plenty that they said, oh, you've missed this, this, and this. So we tried to be responsive to that feedback and add indicators where we could. Of course, so, some of them were giving us their dream list of indicators, and we just couldn't get data for all of them, but we were able to add quite a few. Okay, so next we're going to talk a little bit about this map that we've been developing. So to understand how the pandemic has affected counties differently, we're in the process of creating an interactive map that's going to show us 4 different things. So COVID statistics over time, information from that index that I just talked about, county level demographics. So these are things like a county's racial and ethnic makeup, the percentage of immigrants in that county, age group, and possibly income, as well as the map is also going to show us where MCV funded programs are located. So I am actually going to stop sharing my screen briefly and turn it over to my colleague Jess Warren, who has been developing the map and has a early beta version for us. It's not quite done, but we wanted to just be able to show an early version. I think I've stopped sharing.
Yeah, thanks, Christina. And I will try to start sharing. So as Christina said, this is a very early version, and the data you're going to see represented, it's not the real data for what it says it is. This is just sort of how we're working out what the map will look like. But as you can see, and I can scroll out, we have Alaska, Hawaii, Puerto Rico in here as well. Oh no, okay, there we go. On the right-hand side will be drop-down menus for the index. There will also be drop-downs for demographics and a couple other areas that we're still working out. But users will be able to scroll through the different social determinant of health domains that Christina referred to, and then scroll through and zoom in and out to look at how counties compare to one another. So there'll be all these different layers of the map that you can toggle on and off to sort of compare to one another. The sort of second part of the map, which will be overlaid on top, is that COVID data that Christina mentioned. And let's see if it shows up. There we go. You'll be able to scroll over counties, and a hover box will come up and show what those COVID statistics looked like over time. Again, this is not the data that we will be using. This is just an example. Also, where you see it says food insecure population, percent of population, instead of that, in that box, there will be an indicator of whether or not there's MCPHE funded programs in that county. So yeah, that's sort of a quick overview of what the map is going to look like. These will all sort of be laying on top of one another, so that people can kind of scroll through and see what's going on in different areas. And this map will be used, Christian will talk about it, I'm sure, both for the case selection process and with the communities with whom we work in the later parts of this project. But that's about that. I'm going to stop sharing now, if I can.
Yes. Thank you, Jess. And I'm seeing a number of questions in the chat. By the way, I couldn't see the chat when I was sharing, but thank you for the people who were alerting me that I was sharing my notes. We can take more questions about the map at the end, but just very briefly to answer kind of these more urgent ones, you're not going to be able to pick individual indicators from that list, but to see on the map, but you will be able to pick overall domains. So if you want to look at the education domain or the health domain, we are still exploring whether it will be publicly available or the extent to which it will be. And I'm going to talk a little bit about that now, actually. Okay. Try to reshare. Why do I have so many tabs open? Okay. Okay, and I'm going to do the thing where I switch. So can you all see the notes, see the slides, but not the notes? Okay, great.
Perfect.
So thank you, Jess. So just real quick, returning to this precision paradigm, the tools that we've been developing, like I said earlier, were developed, their primary purpose is to help us choose counties for our in-depth case studies and to understand really the pandemic context and the social determinants of health context of those counties before we begin those case studies. But, as you can imagine, this has been huge effort. And so we are hoping that these resources will be available. They definitely will be available in some form outside of our group. We are just still working out the details of what that's going to look like. But going back to this precision paradigm, when we're thinking about the paradigm, home visiting administrators and community members might, for instance, if they had access to something like this, be able to learn a number of things about the context within a county or a community that might inform how well an intervention might work to impact the intended mechanisms of action, and how well changes to the mechanisms of action might work to impact these target behaviors. So these two arrows over here. For instance, knowing how a community has fared during the pandemic, as well as what resources were or are available in the community to support health equity, could help home visiting administrators to understand how well a county is or is not positioned to respond to a home visiting intervention. So for instance, a community that was particularly hard hit by COVID, for example, might not currently have the resources available to affect target behaviors, and their capability to meet these target behaviors and reach their long-term outcomes might look different from the capability of a community that's experienced not as severe impacts of COVID. Similarly, a community hard hit by COVID might also not really see home visiting as their #1 priority right now, given the large number of basic needs that families affected by COVID might need to have met first. These communities' ability to build motivation towards the specific target behaviors of an intervention might be lower than they had been previously. Overall, though, we think that learning about a community's context in terms of its readiness to navigate a crisis like COVID-19, alongside racial and ethnic disparities within a community, home visiting administrators and community members might be able to use that information to identify priority areas where home visiting services start to promote more equitable health outcomes. So I don't think I have time to go through exactly how we are thinking each of these audiences might be able to use these resources, but just know that we're thinking about each of these audiences and brainstorming ways that different groups might be able to use these tools. So for example, HRSA, since they're funding the project, will absolutely have access to these materials. So we've been working with them to think about ways beyond the project that they might use them. We've been thinking about other federal entities serving children birth through 5, current MCV and tribal MCV grantees, potential tribal MCV grantees, other agencies that support home visiting, as well as researchers and policymakers. So just so you know, as for our next steps, we've kind of mentioned now that we're wrapping up these activities in the next few weeks, we're going to start selecting counties for more in-depth case studies, which I'm sure you all will hear about once those resources come out in future HEART meetings. And then just some quick discussion points. First, as you could imagine, limitations in data have been a huge barrier for us. So as I mentioned earlier, our community advisors suggested adding a bunch of indicators to the index, and we added a number of them, but there were some where we just couldn't obtain at the county level, or they had a lot of missing data, or the information just simply didn't exist. And I'm remembering one of the questions in the chat was about if the map, you're going to be able to look at it at different levels. Unfortunately, most of the data sources that we had were the smallest level. Some of them were available at the census tract, but a lot of them were only available at the county level. So we sort of aggregated to that level. And then going back to data limitations, speaking of which, geographic limitations, but importantly, almost no data was available disaggregated by race and ethnicity, which is a huge limitation when it comes to pushing for health equity. And one of our big conclusions is really that we need more publicly available data that's disaggregated by race and ethnicity. Second, community input has vastly improved the work and has helped to keep equity at the forefront of our goals and efforts. We have sometimes the advisors get broken down into different groups. We have a health equity group, and they've been really, really valuable in kind of pushing our thinking on a number of things. For example, they've helped us to think, like I mentioned, about what indicators to include in the index, how to frame our final products, if the map is going to be made publicly available, what kind of work we need to do around the framing there, and they're going to be continued to be involved in our case studies. As a data person myself, and I'm sure as many of you are, we know that this is not always possible in our work. There's not always funding for it, but it's really been a great experience, and we think it should be incorporated when possible. And then lastly, I think maybe at the end when we open it up for Q&As, or if people want to chat me, either chat publicly or chat me individually or email me, whatever, we are looking for feedback to hear about how would you use the map? Would you use it if you had access to it? How would you use it? Are there others that you work with that you think would use it? And importantly, do you think there are audiences who could benefit from access to the map that we haven't considered? So thank you. There is my email if anybody wants to contact me, and I'm happy to take, I guess, those urgent questions now and then more questions later.
Thank you, thank you, thank you. Wonderful presentation, Christina, and you definitely inspired some great questions from the audience members, many of which I would like to hold off until we have the more robust Q&A session at the end. But there is one, I think, very important clarifying question that you could perhaps answer. Well, these are two. that I feel you can answer relatively quickly. One is, who is the intended target? I'm assuming audience of this research you're conducting. And then I believe you also answered this question earlier as well, but again, I'll just repose it. Will this data be accessible to the public?
Yes, great questions. Will it be publicly available? So, or who's the intended audience? I think I'll start there. So the intended audience, really the primary audience is HRSA, because we're going to be using this map and all this information to select our counties for the case studies, which they'll be, involved in also. And they're going to have access to these tools regardless of what happens out of that. But we're hopeful, like I said, that it will be, that state administrators, that visiting administrators will be able to use it, and that beyond that, if researchers and others have uses for it, that it can be shared in some way. Like I said, we're still figuring out the details of that. And then can you remind me what the second question was?
Thank you, Ann. If the data will be publicly available.
We're still working on that. We think to some degree, and I will say too, we're working to figure out how, once we do pick those 5, communities for case studies, sharing the information that we have about their communities with them, in the context of both the case studies,
Right.
but also so that they can also benefit from the research.
Right. That makes sense. Cool. Well, again, thank you again for the presentation, and we definitely have some more questions for you to answer later on in our session. So if I was you, I'll encourage you to kind of pop into the chat and start thinking through what I hope to be some very thoughtful responses to some very good questions. So moving right along to our next set of presenters, I would like to introduce to everyone Becky Foth, and I apologize in advance if I mispronounce your name, but I believe it's Chi Ikotaki. Please correct me if I completely butchered that. But both Becky and her colleague at Tufts Interdisciplinary Evaluation Research Center. And just for the sake of time, I'd like to just pass the ball to them and allow them to provide a more detailed and thorough introduction if you feel the need to do so. If not, feel free to just dive in with your presentation, one that I'm pretty sure folks are eager to learn more about.
Thank you, Clinton. I will just dive in. So let me share my screen to start. And Jess Goldberg is in charge of saying that she can see my slides. Jess?
I gave you a thumbs up. Thumbs
I
up.
can't see. I'm not looking at
Okay,
Zoom.
fine. Thumbs up, baby.
All right. So thanks for joining us. As Clinton said, I'm Becky Foth, and we're both, Chie Kotake, my colleague, is here. And we're both from TIER at Tufts University, and you can see the title of our presentation there. All right. And just to say, when we applied for this, we did it with the health equity strand, but also with kind of, unique ways of doing evaluation. Just to say, this entire evaluation is using secondary data sources. So really kind of thinking about data linkages and data interoperability, this would be a good example of doing it in practice. And I'll talk about some of the challenges of that when we get to the end. So today we'll be sharing findings from one strand of a larger multi-year mixed methods evaluation of the Early Intervention Parenting Partnerships Program, or EIPP, which is how I'll refer to it throughout. It's a home visiting program in Massachusetts, and I'll just start with a brief overview of EIPP. So it's a home visiting program that aims to promote optimal parental health, perinatal outcomes, and child growth and development through the first year of life. Since 2003, EIPP has served expectant parents and families with infants who experience challenges to their health and well-being due to socioeconomic barriers, structural racism, inadequate prenatal care, and emotional and behavioral health challenges. And the eligibility criteria for the program align with these barriers and stressors. The unique feature of EIPP is that each program is staffed by a multidisciplinary maternal child health team that includes a community health worker, a licensed mental health clinician or social worker, and a maternal and child health nurse. Participants enroll during pregnancy within 3 months of giving birth and can remain in the program until a child turns 1. So EIPP currently operates in 4 Massachusetts communities, and you can see them on the map there, not as sort of filled in as the maps we just saw. So 3 of the 4 communities that EIPP operates in are also Massachusetts McBee communities. And based on the Massachusetts McBee Needs Assessment that TIER conducted a few years ago, we know that relative to the state as a whole, the EIPP communities face much higher rates of poverty, more adverse perinatal outcomes, poorer health outcomes, higher numbers of families involved in child welfare system, and lower achievement test scores among children, to name a few challenges. So this slide presents a quick snapshot of the key EIPP activities. So first, EIPP offers home visits and group services with the core EIPP team. Second, EIPP provides education and brief interventions on a range of topics, including healthy behaviors, healthy parenting, safety, and child development. And these topics are very much tailored to families' interests, preferences, and needs. Third, EIPP offers a comprehensive health development and psychosocial assessments and screenings every 2 months to identify and assess family strengths and needs. And then finally, EIPP offers and facilitates referrals to a range of community programs and services based in part on the information gathered from the screenings and assessments. So we'll just focus in a little more on the bottom row here. Today's presentation focuses on EIPP's role in conducting developmental and psychosocial screenings for children and families and providing early referrals to the early intervention or EI system. In this way, EIPP aims to join up home visiting during the perinatal period, during infancy, with EI that goes throughout the early years. And so before we talk a little bit more, I just want to introduce and remind everybody about EI. So Part C of the Individuals with Disabilities Act is a federal grant program that helps states develop and operate comprehensive coordinated systems of EI services for infants and toddlers with disabilities or developmental delays. EI services focus on enhancing young children's development through various professional supports. In addition to services for children with disabilities or developmental delays, Massachusetts is one of 5 states that provides EI services for children who experience social and environmental factors that may increase children's risk for later delays. Social and environmental factors include young parent age, low parental educational attainment, parental chronic illness or disability, a lack of social support, inadequate basic resources, an open or confirmed child protective services investigation, and substance abuse or intimate partner violence in the home. A key component of EI through Part C is the comprehensive child find system, which includes public awareness activities that promote the early identification and evaluation of potentially eligible infants and toddlers and their families. So that is, child find activities are aimed at ensuring children that would benefit from EI actually get into the system. And this in Massachusetts includes the families experiencing these social and environmental risk factors. So through its screenings, assessments, and relationships with families, the EIPP home visiting program really serves as a child find for EI in Massachusetts. In particular, with a very intentional equity lens, EIPP aims to screen for and identify social and environmental challenges and get families that may not be aware they're eligible for or may not typically enroll in EI services into the EI system and do so at a very early child age. Everyone is familiar with EIPP and just got the reminder about what EI is. We'll describe the evaluation and present study in more detail. So I have a few more slides and then you'll get a break from me and Chie will take the reins. Okay, so here are the main study aims and study questions, and I'll go through these now. This study examined whether the EIPP home visiting program does indeed serve as an effective child find resource to support getting families experiencing social and environmental challenges into the EI system. Specifically, we examined kind of 2 groups of study questions. So first, we examined whether children who receive EIPP are more likely to be referred to and enroll in EI than children from families with similar background experiences who did not receive EIPP. And do EIPP families get into the EI system at an earlier age than these similar families? We also explored some moderators, including race and ethnicity, and the EIPP catchment areas to see if any EIPP impacts on EI utilization varied by families' race and ethnicity or the communities in which they live. Secondly, we focused more on the evaluations. So are EIPP families who receive EIPP more likely to meet EI eligibility criteria related to social and environmental factors that increase the risk of developmental delay, again, relative to other families with similar background experiences who did not get EIPP? So again, Massachusetts is one of the 5 states that includes those social and environmental factors as part of the EI eligibility criteria. So this question really aims to go beyond looking at EIPP as a child find resource in general to really see if it helps reduce inequities by getting families experiencing these social and environmental factors into the EI system. Again, these are families that don't typically get EI in Massachusetts and probably many other states. Now we're going to start talking about the design a little bit. And this one is pretty easy, this next slide. And the one after that morning is a little technical. So if you don't want to listen, you don't have to, you can tune out. So here's a little bit about our evaluation design in a picture. So of course, as many of you are familiar with randomized controlled trials or RCTs, it's not always possible, or I think ethical, to conduct an RCT. But luckily there's many quasi-experimental designs that can approximate an RCT. And covariate matching is a common method used in quasi-experimental designs. So just like an RCT, at the top here, we have our program group. These are parents and babies who enrolled in EIPP during our study period, which was 2013 to 2017. And then to get a comparison group, we base this on the pool of people who gave birth in the EIPP communities during the study period. And we use statistics to create a matched comparison group with the same profile of background and health-related characteristics that influence the likelihood of enrolling in EI, and in this case, EIPP, sorry, and as well, EI as well. Essentially, what matching does, it ensures that the program and comparison groups are balanced on the selected covariates. So you can directly compare the 2 groups on the outcome of interest, in this case, in their EI outcomes. So here's the more technical slide. And if you're, again, not interested, you can tune out. So here's a bit more steps involved in our study design. And again, just to highlight, this entire study was done using secondary data. So first, we used home visiting management information systems to pull the population of all home visiting participants, including EIPP as well as Massachusetts McVie families between 2013 and 2017. I'm not going to get into the reasons why we pulled the McVie families as well, but just to say that we did. And we linked all of these home visiting families to the Massachusetts birth records. So using birth records, we selected background and health characteristics. This is step 2, which we will call covariates to use as matching variables. The covariates we selected included relevant social and environmental factors, such as indicators for poverty, racism, health complications, and community factors that we know drive inequities and may unfavorably influence children's development. In step 3, we use these covariates and we created our comparison groups using a matching method called coarsened exact matching, or CEM. In step 4, we checked for covariate balance. So we made sure that the program and the comparison groups looked the same on all of the covariates we selected. And we grouped them. And the way CEM does it is it groups them into different strata. And I'm not going to get too into the technical part about the strata, but happy to have an offline conversation about that. And I just want to talk a little bit why we chose CEM for those of you who are familiar with other matching methods. So there's other common matching methods like propensity score matching or inverse probability weights, but we chose CEM because it's not dependent on the functional form of the regression model used to create the weights. That is, these other common matching methods are really sensitive if you mess up your regression model. But just to say, we did run a bazillion, and Shea was the lead analyst. We ran, I think, a million different sensitivity analyses using these other methods. And just to say, all the findings were very comparable and the samples were comparable. I also want to note that we created our samples initially with birth records. That was the only data we were given access to at that time. Really rich, great data source, but is a little bit limited. So after we did our initial specification of the samples, we did receive additional data linkages. That's when all the other data we needed for our study started coming in. And so we did re-specify our matching algorithms with the variables we included with some additional variables, things like maternal depression and substance use and other factors that we didn't have good quality data in the birth records. And just to say, all the findings again remain the same, even with the re-specification. But we did lose some sample when we included these other variables. And this analysis I'm presenting today is part of a larger study. And so to keep our samples kind of the same and to really maximize sample size, we went with that original specification. But just to know, we did test everything using these other samples. And then in step 5, that was a technical part, we're done now. And then in step 5, or finally, the final point is that you then use your samples. You essentially have a program group and a comparison group. And we estimated program effects using regression-based methods with using the CEM weights that it creates and robust standard errors. So we looked at 2 sets of outcomes pertaining to our 2 study aims, and these were all generated from Massachusetts EI administrative data. So first we looked at whether children received EI referrals, whether they were evaluated for EI eligibility, and whether they received individualized family service plans, or IFSPs for short, which is an indicator of EI service receipt. EI outcomes were assessed up to age 3, which is the age limit, and we also examined the age of child at first referral evaluation or service receipt. Next, really focusing in on that sort of, the social and environmental factors, we looked at whether children who were evaluated for EI met the eligibility criteria for risk of developmental delay due to biological, social, or environmental factors. The biological is another sort of part of the criteria of the Massachusetts EI, and that was kind of glumped in for this initial look. It was just the way the variable was constructed in the EI data. But then we were able to look more specifically at whether EI was successful at getting families experiencing social and environmental factors into the EI system. We could look at the individual, the presence or absence of the individual social and environmental factors that increase the risk of developmental delay are included as part of the Massachusetts EI eligibility criteria. I mentioned some of these earlier, things like young parent age, child protective services report, lack of social support in the family, substance abuse, depression, things like that. I already mentioned we ran regression models with the weights and just included a few control variables. So for a few things that we know are important that we didn't match on: depression, substance use, preterm birth. And then this is just an overview sample of kind of where we started. We had to apply lots of exclusion criteria, just based on things like, siblings and dates of birth and things like that, and where we ended up. And where you can kind of look is in that final analytic sample for the home visiting group, the EIPP group. You can see that we basically ended up with 85% of the EIPP sample match, which in a matching study is really, really good. So we were quite pleased with that. I'm now going to pass it on to Chie.
Thank you, Becky. Now on to some descriptive statistics for the EIPP evaluation sample. This slide and the next slide display the sample characteristics for EIPP families in the comparison group based on the matching covariates. The proportions are weighted using the CEM weights. As CEM matches the samples exactly, there are no differences between the program and the comparison groups on any of the covariates. As you can see, majority of EIPP sample were receiving multiple types of public assistance during the study period and had multiple children under their care. And EIPP sample was also a racially and ethnically diverse group of participants, with Hispanic participants being the largest group in the EIPP study sample. Now onto our findings. Our first question looked at whether EIPP participants were more likely to be referred and to enroll in EI than the comparison group. We found that EIPP participants had greater odds of receiving an EI referral, being evaluated, and receive EI services than the comparison group. We calculated adjusted probabilities to help with the interpretation, which are presented in the slide. EIPP participants were also more likely than the comparison group to receive referrals, evaluation, and IFSPs at an earlier age. You can see the average ages of referral, evaluation, IFSPs in months to the right of the bars. Most children of EIPP families had at least one EI referral made by EIPP directly. We've heard anecdotally and know from our work that the EI system in Massachusetts serves a larger proportion of families that identify as white. To look at whether EIPP impacts whether stronger for particular racial and ethnic groups or in particular communities, we ran some moderated analyses using families, race, and ethnicity, and community as moderators of EIPP. Overall, we found that EIPP participants across all racial and ethnic groups and in all EIPP communities were more likely to receive EI services relative to our comparison group. So the moderation analyses were not particularly useful. Looking descriptively, however, at the distribution of race and ethnicity among EIPP families in EI compared to the racial and ethnic distribution of all EI participants across Massachusetts, we do see some nuance where we see a larger proportion of Latinx, Black, Asian, and Native American families being served for EIPP relative to the state. Next question focused on the EI eligibility criteria. Among children who were evaluated for EI services, we can see that about a quarter of children of EIPP families met the eligibility criteria for biological, social, or environmental factors compared with 14.1% of the comparison group. Looking across each of the social and environmental factors that may increase the risk of developmental delays, several differences emerged between the EIPP and the comparison group. Among children who were evaluated, children of EIPP families were more likely than the comparison group participants to meet EI eligibility criteria for IPV in the home, substance abuse in the home, child protective services involvement, parent having low social support, parental chronic illnesses or disabilities affecting caregiving ability, and multiple trauma. And back to Becky to wrap up.
Thanks, Chie. Okay. So EIPP was highly successful in connecting families to the early childhood system of care, notably EI services. Findings revealed that relative to the matched comparison group, EIPP families were more likely to be referred to, evaluated for, and receive EI services. They were also connected to the EI system earlier, about 10 months for referrals and 3 months each for evaluation in IFSPs. So EIPP is an effective child find resource in Massachusetts. We also found that EIPP was particularly successful in early identification of children who are at risk for developmental delays due to the presence of social and environmental factors and getting them into the EI system. Early identification of potential risk to children's development and well-being is a critical component of an effective EI system that promotes equity. I'm now just gonna, oops, did I skip 2 slides? Nope, I'm here. So let's take a quick look at the EIPP evaluation with a precision lens. The piece of the larger evaluation we present today was somewhat blunt. It really just focused on EIPP versus comparison group differences. The sort of magic was really in the method that we used and all the data we were able to get. But there are aspects of the evaluation that align with a precision lens, using some of the findings from our mixed methods implementation study to guide us. And I'll just highlight a few things here today, mainly in the techniques box. So focusing on techniques in the intervention box there in the upper left. While we did not analyze the effectiveness of specific techniques in today's study, we do know from our implementation study that offering EIPP families regular health and psychosocial assessments and screenings and checking for unmet needs was an important technique used by the multidisciplinary team in EIPP. EIPP staff explicitly mentioned using findings from the screens or information gleaned through informal conversations or simple observations of families to make referrals and support families to get into EI. EIPP staff spent a lot of time building trusting relationships where families could talk about their challenges. We heard this directly from families. The community health workers, one of the EIPP team members, are typically from the EIPP communities, and in many cases have similar racial and ethnic identities and speak the same languages as families, and thus were very well placed to advocate for parents' needs. Further, EIPP staff had strong relationships with EI in their local communities. In some cases, they were co-located or even shared staff. So they made extremely warm handoffs, hot handoffs, and even informed the nature of the IFSPs, which are the plans you make with families when they get in EI. Focusing on mechanisms of action, that box to the right, the techniques used by EIPP home visitors enhanced the opportunity for and capacity and willingness of EIPP families to access the EI system, which they might not have in the absence of EIPP, particularly since they may not have been aware of the eligibility criteria in Massachusetts that related to social and environmental factors, or they probably had lots of other barriers to getting evaluated. Focusing on the target behavior, I think our study demonstrated that quite clearly, that participation in EIPP was associated with getting evaluated and receiving IFSPs or EI services, particularly for families that may not have known they're eligible, as just described above, or were not comfortable getting evaluated or faced other barriers. And then finally, the context box. While our moderation analyses that GA talked about were not particularly informative, the findings were so strong for EIPP as a whole, the moderators just didn't really pan out. Context has really been critical to this evaluation, given the background and experiences of the EIPP families, the communities they live in, and the systems and structures that impact their lives. Our evaluation also unveiled the critically low pay of EIPP staff, despite the important equity work that they do. So I think we can conclude from this evaluation that EIPP is highly successful at getting families facing a range of systemic barriers and inequities into the EI system. And I want to kind of close just by talking a little bit about the data piece very briefly. So while the results were favorable, it took a lot of effort to get here. You can see in the slide a list of the databases we need to conduct the larger EIPP evaluation. In most cases, we did not have a unique ID to link on, so took lots of fancy kind of matching techniques to get sort of families matched up in the different data sets. The different data sources require different levels of approval, different data storage and security requirements. And once we had all that sorted, which took a very long time, we had a lot of waiting time to access some of the data. So integrated data systems and data exchange standards could support, in this study, could really support that longer term tracking of these families' referrals and their healthcare use and children's well-being and development through school entry. And overall, I think, the use of secondary data for evaluation definitely reduces data burden on programs, staff, and participants, and significantly saves costs. So I'm all for it, 100%. But the current systems are really laborious and challenging, which I think stymie efforts to use these data for evaluative purposes. Given our efforts, though, we really do hope that our study serves as an exemplar in Massachusetts for similar studies in home visiting with some of our other partners and friends for how to establish and streamline data sharing systems between researchers or evaluators and state agencies to conduct evaluation. And then finally, just to acknowledge the Massachusetts Department of Public Health for funding this evaluation, and of course, all of the people who contributed data to the study. And I will stop sharing.
Wonderful.
Why am I blanking on how to stop? Oh, there it is. I was like, where's the button? There we are.
Yeah. It happens to the best of us.
Oh my gosh.
Yeah. Well, thank you for the presentation, Becky and Chie. And now I would just like to open it up for questions, right? I do want to start with some of the questions that were posed in the chat. One specifically from Morgan, and this will be directed towards you, Christina. First, before I even pose the question, Morgan, if this was a college course, you'll get an A for class participation, because every time I look in the chat, Morgan is coming with question after question after question, and they're all good ones. And so the first one is, Christina, do you see any, or your whole team, right? Do you see any potential danger and or limitations in generalizing community level characteristics with missing data to potentially inform individual level approaches to home visiting work?
Yeah, definitely appreciate the questions, agree on the A+. And I know Morgan's previous question was about how home visitors would know how to use these materials. And so I'll kind of answer both of them together, which is essentially that the map is not really intended to be used in that way, such that we would expect individual home visitors to be using it to sort of inform their individual service delivery. Although we do hope that it can kind of be used if access were kind of broader, to be used to kind of inform their general knowledge of the context of those communities. And then of course, getting into those communities and sort of knowing them better and understanding their needs, but just as kind of like this broader macro level context. And then in terms of potential dangers and limitations, we've been thinking a lot actually about, this is why we're trying to be really careful and not just release all these materials and say, go for it, but really thinking about the framing in terms of, what this map can and cannot do, what it's intended to do. We've had a lot of questions about racial equity in terms of, if this map shows that, COVID was much worse in certain areas with high percentages of people of color, are people going to, is that going to increase stigma? And, we are definitely thinking very carefully about that and want to make it very clear that the map is intended to show the resources that communities had going into the pandemic. And if there's an overlap there with historic disinvestment in those communities, then that's not so surprising. But being careful about all of those things. So we appreciate another thing to kind of think about. And in terms of home visitors, we will be, when we go in to do those individual case studies, we're going to be sharing a lot of that data. And so thinking about how, almost as like a pilot, like how are they using it? Would they use it? What are they telling us about it? So we'll be able to get some more feedback from them.
Cool. Sounds good. I do want to open the floor up to Cynthia, I believe. I saw your hand pop up out of the corner of my eye. So if you still had a question, feel free to, pose it at this time.
Sure. So both presentations were great. So thank you both so much, and all of you. But Becky, you mentioned hot handoffs, which of course got my attention because I'm passionate about thinking about how we make connections across services. So I guess one question for you guys and the TIER team is, you may have said this and I missed it, but was there any connection with primary care providers who also have a responsibility for ongoing screening for both, developmental concerns and social risks? And I don't know if you have any access to those data and the disclaimer is, as someone who's trained in primary care, I think we don't do a very good job of consistently and reliably screening. And so in Massachusetts, probably most of those kids had primary care, but I was wondering if you might be able to comment if you have that information, even if you didn't have a chance to look at it.
Sure. I can comment in a couple ways. We definitely have like who referred each person, and 70. Just to note too, that many of the families in both EIPP and comparison group, they needed lots of nudges. So it wasn't the first referral that got them into EI. They needed kind of 4, about that, maybe 3. I forget the exact average off the top of my head. But we have the referral source. And for EIPP, it was sort of 75% was EIPP. So they were that was the main referral source. But we definitely know that the comparison group was more likely to get referred by their PCP, by a community health clinic, things like that. We also know kind of more from the qualitative work we did that in the 4 communities EIPP operated with, some had wonderful relationships with the OBGYNs and primary care, and others really struggled. They just couldn't get a hold on them. So I think there might not been as much communication from EIPP and the primary care within EIPP programs. So they definitely were a referral source. It's just for the EIPP families that was just such a strong referral source because they just had such strong relationships with the EI systems. Like I said, the hot handoffs, but also they were just doing that regular every 2 months screening. And so they were so aware of these families' challenges and we're just like, here's another service for you. This one's going to end soon. Here's the next thing, we can get you into, and it'll be a good, service for you. And, we have qualitative data where, some of the EIPP staff said, we helped create the IFSP, we helped staff it. Like we made sure it was right for this family. So I think that was just a really important personalization that you probably weren't getting with your pediatrician,
Yeah,
that was
so
a
it's almost
long-winded
as though
answer.
no, but it's almost as though EIPP fulfills the promise of bright futures, which should guide, health supervision. So I can chat with you more about it offline, but I think it's a really important point to elevate that, many, not all, but many had primary care and it was not sufficient.
Yeah.
So thanks.
I do see a question in the chat about any potential covariates or confounders that you would have liked to include. And I'm happy to respond to that. I mean, we did the best I could. And I just want to say with any matching study, you are completely beholden to the data you have access to. So we tried our best to really find most things. I would say the one area that was tricky was Child Protective Services. So our main matching was with birth records. And so most, Child Protective Services usually doesn't become involved till birth. And there's not data in the birth records on that. We did, so that might be one area where, we weren't able to control for. And so it may be that EIPP was just more likely to be in Child Protective Services. Interestingly, though, as I was just mentioning to Cynthia, we do know the EI referral source. What we saw was actually the comparison group was much more likely to get referred into EI from Child Protective Services. So it does suggest some very heavy involvement on their end as well. So I think, again, it's that point that we really do think that the EIPP group was just doing a really good job at getting these families into EI system.
Got you. Do we have anyone else from the audience who would like to pose a question or two? We have 6 minutes remaining for today's session. If not, I can pose one. Christina, I was listening to your presentation and thinking about it within the context of COVID, right? Which was a global pandemic that affected everybody in some shape, form, or fashion, right? So I'm just curious to know, what do you think about the different ways that, we are looking at the COVID-19 data, specifically from like slides 13 to 18, I believe, and does it resonate with how you were thinking about COVID-19 impacts or your experience with COVID-19?
Yeah, and this is, you know, I'd love to hear from others. This is an area where we have been seeking input from our community advisors. And, you know, one of the really interesting things that we heard recently was like, yeah, COVID was COVID. There were cases, there were deaths, there were hospitalizations, but like what really impacted our community was school closures, was access to benefits, was all of those, you know, secondary impacts of COVID. And so, you know, that's not what we're measuring. We have pre-pandemic measures of those things, and it would be interesting kind of, you know, in future work, certainly not in the purview of this project, but to think about some of those things. And I think in the case studies, that's really where we're going to be able to get a lot more information about how COVID impacted different communities, rather than just thinking. And I don't think we can assume that it was because we're seeing, for instance, you know, in some counties, there's this really high correlation between cases and deaths. And in others, there's really not. So it's, you know, what's going on there? If there are high cases but low deaths, what is that county doing differently than other ones? So we're just trying to think as much as possible within the confines too of the project about how to use those data.
Cool. Becky and Chie, a question that I have for you all, you know, is what do you think accounts for the differences in the proportion of non-white children in EI in the state overall versus non-white children referred into EI through EIPP?
Yeah, I mean, that's something I think we were able to, you know, kind of unpack with our qualitative, but also I think just my own hypotheses that, you know, EI is a universal program. I mean, not everyone gets it, but it's open to everybody, right? And it's supposedly accessible to all. But I think with any universal program, you know, it does have to do with resources, time, information, you know, community norms, other factors. And I think we do know what's happening in Massachusetts, and I'm sure other states as well, is that you do have a disproportionate number of affluent families and white families accessing EI. If they can get it, they get it. But what EIPP did, and I think is provide, and I think home visiting programs generally in Massachusetts, they provide that access, they provide the resources, the information and support to really even the playing field and get families that can and would benefit from EI into the system. And so I think, you know, that's a really important piece about leveling the playing field. I also think, as I noted, that the EIPP community health workers are from the communities in which they work. They speak the languages, they can really advocate for parents' needs. So I think they were really, I think in the study we did, we talked about who does what, the community health workers were often the ones that were the connections to families, getting them into the resources. And so I think that probably has to do with just having that extra step and extra support really to help families bridge that gap. So they were able to get the services that they deserve and that they need.
Got you. Well, I'm looking at the chat and it looks like Becky and Chie, we have another clarifying question of sorts. And I think you just somewhat spoke to this question, but this would be a great opportunity to elaborate and expound. When you say an average of 3 to 4 referrals before enrollment, does that mean referrals from 3 to 4 different sources?
I don't have that information to hand. I can certainly look at it. So in most cases, it was that EIPP was the first referral source, and they would often do it again. But again, this was not, you know, I was talking to Jess about this yesterday. This was not a neat, clean, easy thing. It wasn't like one referral in, they got evaluated immediately, they got services and well on their way. It was really complicated with both comparison and EIPP. Some families had 7 different referrals. They went into EI, they left EI, they went back in. So it was pretty complicated. So I think, Chris, I can definitely investigate that more and we can have a discussion about that. But it was definitely not a clean, easy thing. But again, I mean, this is where blunt quantitative work is good and bad. What our study showed is that EIPP in some ways, you know, was the driving force in getting a lot of families that really needed EI services into the system. But it wasn't this clean, neat thing where they made a referral and everything happened.
That makes sense. That makes sense. Well, it looks like we're at time. So again, thank you everyone for joining us today. Hopefully you walked away from today's presentations enlightened and also inspired by the work that our presenters are doing at their respective organizations. and we look forward to having continued dialogue as this work continues to evolve over time. I'm quite sure that our presenters will have much more to share about the evolving projects as they continue to do this very important work.